Hello, everyone. My name is Kajali. I'm one of the GI Fellows at Loyola University. I will be discussing the article published in Annals of Internal Medicine in October 2022. This article is related to pregnant patients with IBD and the use of anti-TNF in this population. Briefly, treating pregnant patients with IBD is a challenging area. There are several observational studies that give evidence in support of the safety and the efficacy of anti TNF in this population. However, the ability of this medication to cross the placenta in the later stages of pregnancy makes the provider anxious. In addition to that, there is no robust data to clarify the effects of these medication on the IBD disease activity during pregnancy, as well as the effects of these medication on the pregnancy outcomes as well as on the offspring. Hence, I present this observational cohort study that was done emulating a target trial to evaluate the benefits and risk of these medications when they are used or continued after 24 weeks of pregnancy in patients with IBD. This study was based on a national health data system, which was the largest data system in France. Data was pulled for all pregnant IBD patients between January 2009 and December 2020. This is an emulation of a target trial, meaning the design principles of a randomized controlled trial were applied on this observational cohort. There was no randomization, but inverse probability was used to reduce the confounding. A propensity score was calculated based on the maternal IBD and pregnancy characteristic, and then propensity score matching was done to reduce confounders. The endpoints that they focused on included the disease activity, pregnancy outcome, and any serious infections. In the PICO model, the population that they were looking at were pregnant patients with IBD who were exposed to anti-TNF prior to 24 weeks of pregnancy. The intervention arm would be patients who had this medication continued between 24 to 32 weeks of pregnancy. The control arm would be patients who did not have this medication continued between 24 weeks to 32 weeks of pregnancy. And the outcomes that they were looking were related to the disease activity and pregnancy outcome. Key definitions in the study: the diagnosis of IBD was made based on health insurance information related to their hospitalization or pharmacy claim. Maternal IBD relapse was defined as at least one oral or rectal steroid or budesonide use, any IBD related to hospitalization or surgery during later stage of pregnancy, meaning after 32 weeks to about 6 months after delivery. The adverse pregnancy outcomes that were included were hospitalization, need for cesarean section, stillbirth, prematurity, low or large birth weight, and serious infections in offspring. The study design is depicted in the flowchart. In the database, patients with IBD were identified, out of which pregnant patients with IBD were identified. In a cohort of 68,000 pregnant patients with IBD, 62,000 patients were removed as the pregnancy did not reach 24 weeks, or these patients were not exposed to anti-TNF prior to 24 weeks. When they went forward with 5,413 patients, they further removed 42 patients as they were exposed to other biologic, small molecule, or methotrexate prior to 24 weeks. They removed 22 patients as the pregnancy ended in abortion, another 56 patients as the pregnancy never reached 32-week mark. The final cohort was 5,200 patients, and which was further divided into 2,403 patients that were exposed to anti-TNF between 24 to 34 weeks, and 2,890 patients where the anti-TNF therapy was stopped or not continued between 24 to 32 weeks. 55% stopped therapy after 24 weeks. This is a busy slide. When comparing the two groups based on the maternal characteristics and the pregnancy characteristics, overall, they were very comparable. The median age of the pregnancy was around 29, so mostly patients were young patients. Most patients had their first pregnancy, and pregnancy related hospitalizations were few but not overall different between the two groups. When comparing the IBD characteristics, more patients with Crohn's disease was seen overall. The median duration of IBD was slightly longer in patients where the anti-TNF therapy was continued. Prior to 24 weeks of pregnancy, in the group where the anti-TNF was continued, experienced slightly more IBD-related hospitalization, had overall higher cumulative prednisone equivalent use, and thiopurine use. When looking at outcomes, in the group where the anti-TNF therapy was stopped, were at higher risk of IBD relapse between 32 weeks of pregnancy to 6 months postpartum, with the risk being higher in the postpartum period. When looking at pregnancy outcome, neither group was at higher risk for pregnancy-related hospitalization or need for cesarean section. Neither group were at higher risk for stillbirth or abnormal birth weight. However, in patients where the anti-TNF therapy was stopped, preterm birth was more common. When looking at serious infections, we all know that patients on anti-TNF therapy are more likely to develop infections due to immunosuppression. In this study, both groups were at comparable risk of serious infections. Overall, the type of infection or the site of infection did not make a difference. So key takeaways are continuation of anti-TNF throughout pregnancy is associated with better IBD disease activity and less rates of prematurity in newborn. Continuing this medication does not seem to put patient at a higher risk for pregnancy-related outcome or susceptibility to serious infection in the offspring. So overall, a thumbs up to anti-TNF during pregnancy. So overall, the key strength of this study is a large database study where the patients were looked at for an 11-year long time period. The cohorts were propensity score match, which reduces the confounders. At the same time, the limitation of the study is that it's a database study that does not provide key data points like clinical characteristics, presentation, biomarkers, including CRP and calprotectin. They excluded patients who underwent abortions or had early preterm deliveries, which may predispose this population to selection or immortal bias. So overall, it's a well done study. It gives us key information of anti-TNF medication use in pregnant patients with IBD. I'm grateful for all of you to hear my presentation, and I'm excited to discuss more on Twitter. See you all there.